Okay. Good morning. Today we'll have two short case discussion. One on congenital hernia, one on management of hypospadias. Dr. Shumon Pal, who is third year junior resident at MR Bangal Hospital, present both the cases. And with us today will be Professor Kalyani Basu, who is Professor of Pediatric Surgery at NRS Medical College. So, Dr. Shumon, you share your screen and present first the congenital hernia.
Good morning, Madam and Sir. I am Shuman Pal, presenting a case on congenital inguinal hernia. Patient particulars. My patient is a 1 year old, 1 year, 5 months old male child, hailing from Hingolprotha village, North Chব্বিশ Pargana, from West Bengal. Respondent is mother. Chief complaint is swelling in the left groin and scrotum since birth. Present illness. As per mother, a swelling in the left groin of the child was noticeable since birth, which used to get prominent whenever the child used to cry. The swelling initially was at the groin, which gradually increased to a size of approx 6 into 3 centimeter currently, extending up to the scrotum as the child grew. The swelling increases when the child cries, screams, coughs, and diminishes in size slowly as the child lies down supine. No history of pain over the swelling, no history of irreducibility of the swelling, no history of pain, vomiting, abdominal distension, or absolute constipation, no history of chronic cough, constipation, difficulty in passing urine, no history of fever. History of past illness, no history of any previous operative intervention, and no history of medical ailment. Birth history, antenatal history, maternal age is 26 years, no history of OCP use, oral contraceptive pills. And perinatal history, birth order is first term delivered by cesarean section. Birth weight was 2.5 kg approximately, exclusively breastfed. Postnatal history, nothing was that much significant to remark on. And immunization history, all immunization received as per schedule. Personal history, diet a vegetarian one. Sleep pattern and appetite is normal. Bowel habit is normal. Bladder habit is normal. Family history, both parents are healthy. He is a single child. No other member of the family suffers from this condition. Summary, a 1 year, 5 months old child presents with a gradually increasing painless swelling in the left groin extending to the scrotum, which decreases in size on lying down supine and becomes more prominent when the child strains like crying and coughing. No signs of irreducibility and strangulation. The child has no history of previous operation, chronic cough, or micturition difficulties.
Madam, you will finish up the examination or you have some questions here?
Okay, let him finish up the examination.
Okay, fine.
Examination. General examination. The child was examined in well-lit room after taking parental consent and exposing umbilicus to the mid-thigh in standing in supine postures with straining maneuvers whenever required. Child is active, alert, playful, no cyanosis, clubbing, pallor, and icterus. Anthropometric measurements. Height was 86 centimeter, weight 8 kgs. Mid upper arm circumference is 13 centimeter. No other congenital deformities detected. Vitals, pulse rate 96 beats per minute. BP was 90/60 mm of Hg. And SpO2 99% in room air, respiratory rate was normal and temperature was adequate. Examination of the abdomen. Inspection. Abdominal contour is scaphoid. Every quadrant of abdomen is moving with respiration proportionately. Umbilicus is normal in position and shape. Swelling was present in on the left inguinal region, extending up to the end of the scrotum, starting from the point just above the almost the mid part of the inguinal crease. It was piriform in shape. Swelling was increasing in size on straining. No fullness of loin was noticed. Skin all around the abdomen and over the swelling appeared normal. Penis was normal in position. Palpation. On palpation, swelling was present on the left inguinal region, extending up to the end of the scrotum, starting from a point just above almost the mid part of the inguinal crease. Size was 7 into 2 centimeter, medial to pubic tubercle, piriform in shape, soft on palpation, and swelling was increasing in size on straining. Temperature over the swelling is comparable with other part of the abdomen. Getting above the swelling was not possible. Expansile cough impulse was present on the swelling. Swelling was reducible. On palpation, other organs were found to be within normal range. No deep tenderness was noted. Both the testes were normal in position and shape. Percussion over the swelling had a resonant no, and on auscultation over the swelling, bowel sounds were audible. Systemic examination, CVS, S1, S2, audible, no added sounds, CNS and respiratory systems were found to be within normal range. The summary. A 2-year-old male child presents with a gradually increasing painless swelling in the left groin extending to scrotum, which decreased in size on lying down supine and becomes more prominent when the child strains like crying and coughing. No signs of irreducibility and strangulation was noticed. The child has no history of previous operation, chronic cough, or micturition difficulties. On examination, a pyriform shaped swelling of size 7 into 2 centimeter extending up to the scrotum in left inguinal region was noted medial to the pubic tubercle, which had a cough impulse on palpation and increase in size on straining. No signs of complications was present. Provisional diagnosis: left-sided uncomplicated congenital inguinal hernia in a 1-year, 5 months old child. Content is found to be intestine.
Thank you, Dr. Shuman. But Professor Shah, I think it's good that he presented such a detailed history, but this will be a short case. So,
but in DNB, madam, in DNB, there is no short case. In DNB, they put 4 cases, which is to be presented like a normal long case. In DNB exam, there is no term called short case. So they are supposed to present like a long case even in DNB examination.
I didn't have that knowledge. Anyway, good. I think your history present. What would be your differential diagnosis?
Well, it may be a lymphedema, lymphoma.
You please remove your mask. You are not audible through your mask.
Am I audible, ma'am?
Yeah, you are audible.
It may be due to some origin, maybe lymph node. That is
no.
Maybe
confined to your findings. Why do you jump to lymph node? Madam has asked a differential diagnosis. You have given your findings.
Differential diagnosis.
Based on the findings, you should put your differential diagnosis. It's inguinal swelling, you said.
It is
swelling.
It may be an abscess over that region. Abscess.
You said there is no tenderness, no fever.
Abscess. He said hernia. Can it be something else?
Which is the commonest?
Congenital hydrocele.
Congenital hydrocele may be there.
Congenital hydrocele. So then comes the question, what is the difference between a congenital inguinal hernia and a congenital hydrocele?
Ma'am, in case of congenital inguinal hernia, on examination, we can, first from the history, we will find that it in this case, it was since the birth, and it was reducing on its own when the patient used to be supine, and when used to strain, it used to increase. But in case of congenital hydrocele, it doesn't appear in that way. And nextly, on examination, getting above the swelling was in case of examination.
No, you're out of track.
Simon, the difference between congenital inguinal hernia and hydrocele, the pathology is the same. It's due to the persistent processus vaginalis. And so what is the processus vaginalis? That is the thing that records the path of descent of the testis. It goes ahead of the testis. It's only an outpouching of the peritoneal diverticulum, sort of outpouching sock-like peritoneum, which wraps the descending testis all round and traverses the inguinal canal and comes to the bottom of the scrotum. If that processus vaginalis persists throughout its course, then it can form congenital inguinal hernia. If the diameter is large omentum or intestine can go through it, and then the diameter is very narrow, then only peritoneal fluid comes to be hydrocele. So many people describe congenital hydrocele as fluid hernia also. So there is different pathology from adult hydrocele to that of congenital hydrocele.
Okay.
And congenital hydrocele should be your first differential diagnosis. What is
And-
your second differential diagnosis? What should be? Do not think of in any other line. Think of this line of persistent processus vaginalis. It can be closed at both ends, towards the peritoneal cavity, towards the upper end of the testis, and in between a sac filled with fluid persists. What do you call it?
What is that?
Insisted.
No, ancestral is in between. If it is up to the groin, inguinal canal region, and the scrotum, what is that?
That is a funicular hernia.
That should be, the deep ring is closed. It cannot be hernia.
That is congenital funicular
Hydrocele.
Congenital funicular hernia.
Okay. During your examination part, I think you should mention separately about the opposite groin. When you said that
Other
both
groin.
are palpable, and I agree to that. While mentioning the site which is affected, you mentioned that I could palpate the testis separately from the swelling, and while examining the other side, there is no impulse on coughing or crying, and there is, what is silk glove sign?
Silk glove sign.
Sorry, ma'am, I don't know that.
First, many a times in children, the hernia is a bilateral, congenital inguinal hernia is a bilateral condition. It is not due to any neuromuscular defect or due to any connective tissue disorder. It's the same pathology lies on both sides. It may not appear simultaneously, especially if there is left-sided hernia, inguinal hernia, the right side is also to be affected. Many a times it happens so that after you have operated on the left side, 3 or 6 months later, the right side appears, and the parents come to you with the allegation that, doctor, you have operated on one side and the other side is now affected. So you intimate them beforehand, before you operate, that the other side might also appear. So while describing your examination part, you describe the other inguinoscrotal region separately. And you didn't mention anything about the cord, or I think a little bit of elaboration might be required about the testis size, and many a times it is associated with undescended testis also. So you'll have to keep that part in mind. Okay, you proceed. Sir, please
Yes.
ask some questions.
And a few things in the presentation, when you have summarized the history, you say no signs of reducibility or strangulation. When you summarize the history, that should be symptoms. No symptoms of irreducibility and strangulation. If you say signs, that is a part of finding.
That is a finding.
Second is, you said in the examination, when you examine a child of 1 year with this amount of swelling, percussion is redundant. You cannot make out anything by doing percussion. So to avoid percussion, that cannot differentiate between your intestine or omentum. In children, in the 1 year, 5 months old child, you see your finger. Why do you percuss? So percussion you should omit in congenital hernia. The main difference between what Madam said is congenital hernia and congenital hydrocele. The basic difference is the pathology is same, patent process vaginalis. If it contains fluid, it is congenital hydrocele. If it is having some contents like omentum or intestine, it is
Congenital hernia.
And Madam asks one question: silk glove sign. In congenital hernias, the is very thin. Okay, so you may demonstrate transillumination in the sac. Unlike in adult, if you have a hernial sac, you never appreciate transformation. In children, transformation may be present. So this part you should. Otherwise, you have covered the history well. Okay, madam, please.
How will you like to perform any investigation apart from those required for operative treatment? You have to operate. Is it so? Is there any role of non-operative treatment in case of congenital inguinal hernia?
No.
Why?
No.
Why you need to operate for all patients?
Because it is a patent processus vaginalis, and it will it generally gets obliterated when at 9 months of
What is the
so-
reason for operating? Because pediatric surgeons will say that if you don't operate, there is high chance of
strangulation.
yes.
Chance of strangulation and obstruction is even higher in neonatal age group. So in neonate, if a neonate presents with congenital inguinal hernia, you will have to operate at the earliest possibility within the neonatal period after doing basic investigations. But if a child presents in a later age, you can perform the operation on what basis? Will you do it as after admission, after all investigations necessary for general anesthesia, or is there any other mode? Especially for children of this age group, there is a great psychological impact of separation of mother from mother. To avoid separation anxiety, we can perform this operation on daycare basis.
Okay.
Hello, your screen
Yes,
is no
ma'am.
longer
Yes.
visible to me. Dr. Suman, you can
Yes, ma'am.
perform on daycare basis.
Okay, ma'am.
During the infancy period. We should not wait for it to become irreducible or to develop strangulation. But what about congenital hydrocele? Do we operate it immediately?
No,
The
we
sac
can-
diameter of the canal is very narrow. Only fluid comes. And most of these resolve by the age of 3 to 5 years. So for congenital hydrocele, you can reassure the parents that, look, this will most likely disappear. So we will not operate right now. We'll wait and watch. So timing of operation is very important. For neonate, operate immediately. For infants, prepare the patient for surgery and then operate. And for hydrocele, wait and watch till 3 to 5 years, or unless it's a very huge hydrocele and it's unlikely that it will get absorbed. So what are the investigations that we like to perform? I don't want to listen about routine investigations or not. I'm just interested. Are you interested in kind of imaging?
Ultrasonography of KUB region as an extension of my clinical. I will go
region,
first.
right? You
Some-
are, yeah, the child presented with congenital inguinal hernia. Why do you want to do KUB, USG, KUB? Okay, it will give you an information like normal kidneys, urinary bladder, normal. You are almost in the track, but you are missing a fine point. You will have to ask your sonologist friend to look for post-void residual urine. And it's always very good to observe the stream of urine if possible. Then you can easily rule out that there is no, if it's a good projectile stream, then there is no bladder outflow obstruction. In case of bladder outflow obstruction, if you treat the hernia and the bladder outflow obstruction persists, then there will be ongoing renal damage as well as chance of recurrence is also very high. So, and ultrasonography of bilateral inguinoscrotal region. So you want to detect the other side also. So suppose the sonologist says that you have a persistent processes on the other side. Will you like to operate at the same sitting?
No, madam. Because
no, we should wait for clinical appearance of the hernia on the other side. Many a times it happens so that the mother comes and says that there is hernia, but you cannot detect it clinically. And then there is the role of sonography comes, that many a times the sonologist will be able to pick up. And in those cases, especially now everybody have got mobile cameras at home, ask the parents to keep a picture when the swelling appears. Do not operate until and unless you have any tangible evidence of inguinal hernia. Only on parents' history, do not operate. You must demonstrate that there is processus vaginalis, either by clinical photo from parents during the time of swelling appearance or by sonography establishment that there is persistent processes. What is the operation that is done for congenital inguinal hernia?
Herniotomy of that.
Herniotomy. So that is, suppose it's a very huge hydrocele at 6 years of child. So that has gone beyond the course of spontaneous resolution. What operation will you perform for that case? If it's a congenital hydrocele, 6-year-old, a big one, say 10 centimeter hydrocele.
So herniotomy and
No, it's called high ligation of the persistent processes. There is no hernia, only fluid comes, no content comes to that sac. So, the post-op order that under general anesthesia, high ligation of persistent processes has been done. What do you do with the huge hernia, with huge hydrocele sac? Do you do any eversion? How will you get rid of that thing? Because parents have come to you with that swelling only.
You have ligated the neck of this.
Neck or high ligation of
what about the distal fluid that is accumulating?
The fluid is to be drained out and generally it gets absorbed.
Then that means you have to transect.
Make your life hell. You just lay open the sac right up to the upper pole of the testis so that the fluid does not accumulate. It gets reabsorbed. Okay, what
ligation and lay open the distal sac.
Suppose there is bilateral congenital inguinal hernia in a male patient. What will you do? Will you operate on the same sitting? Yes, there is no harm. But only do not let the patient go home. Keep admitted for at least 1 day or till the patient has passed you. So there comes the next question. What are the possible complications of...
Madam, should they say laparoscopic repair also? Laparoscopic herniotomy?
Yes, next comes. So what is the role of laparoscopic repair? Which patients, for which patient will you recommend?
Particularly bilateral. I'm trying to understand. Patient who has got a inguinal hernia, you operate very, very small incision. So patient has no inguinal canal. But for bilateral hernia, this can be a better option. Where you just like it.
The role of gender, especially for females. If you put in a scope and occlude both inguinal canals from inside the abdomen, especially if we do an open herniotomy in case of females, the ligaments which are round ligaments, those are divided because we occlude the inguinal canal. But in males, we do not do that. But the chance of uterine prolapse at later life has been found to be quite significant if after open operation bilateral of inguinal hernias. So for females, it is strongly recommended that you do laparoscopic occlusion of the inguinal canal. So can we proceed for post-op complications?
Yes, yes.
What post-op complications do? Sorry to interrupt. Per-operative, what are the things that you will be very careful about?
Intraoperative.
During operation.
Not to injure the pampiniform plexus and cord structures.
You should never touch the vas, even with a vascular forceps. Do not touch the vas. The chances of vessel occlusion and vessel damage is as high as 25% after uncomplicated inguinal hernia repair. So be very careful about the vas. It is very narrow, very fine structure. Can you tell me the relationship of the hernia sac to that of the cord in a child?
If you expose the area, where do you find the sac? Medial, lateral, anterior, posterior?
It is on the posterolateral.
Posterolateral. What is posterolateral?
How can it go to posterior?
The sac lies anteromedial and the cord lies posterolateral. Is there any role of deep ring tightening?
Any role for deep ring tightening? Do you narrow the deep ring?
No, ma'am.
No.
No. In case of a very huge hernia, congenital hernia, you will have to do a deep ring tightening. And one thing you will have to be very careful in children, it is not unheard of having a sliding hernia. It may be the one wall of the bladder on the right side, the cecum might be coming through the hernial orifice. So in that case, you have to make an incision on the peritoneum, on the lateral aspect, an inferior aspect of the cecum, reposition it in the abdomen, close the peritoneal cavity the way you close peritoneum after any laparotomy. Then you perform the excision of the ligation of the sac. Simple ligation will not cure a sliding hernia. You have to be, bladder injuries are known to occur during operation of huge hernias. Those are called rather scrotal abdomen. Huge hernias, even in children, it is possible.
So if you're sliding hernia, you cannot straightway transect the neck of the sac. In sliding hernia, what madam said is, this is one technique where you reperitonize the sliding component. Make a U incision, close this, and the content become now inside the sac. And then you twist and transect. Then madam was asking post-op complications.
Post-operative complications. Commonest. I have given you a hint already. Retention of urine. Do not let the child go home till he or she passes urine after the operation. Is there any role of post-operative antibiotics?
Post-operative antibiotics generally given, but it is not required as such.
Don't say that. You say that it's a clean surgery, it is not required. Then what you do?
It's a clean surgery. So you bring the child from home, send him or her back to home. You don't have to, even just single shot antibiotic during induction is sufficient. Even that is not necessary. You don't have to give any antibiotics. Okay. So you just give the child some post-operative analgesics in the form of simple paracetamol. Keep an occlusive dressing for 24 hours. After that, the child can have bath, normal bath, and can apply some topical antibiotics if required. Sometimes, in case of huge hernias or hydrocele operations, you need to give some scrotal elevation, but suspensory bandages are not available for children. So what do? You ask the mother to use a cotton undergarment, which is just one size smaller than that, what is required for the child. That's all that is necessary. Will you call the child back for OPD visit?
Yes, ma'am.
Of course, for inspection of the wound. Okay.
Okay, madam.
You can also want to ask any other question on this topic?
No. We have covered almost everything. This is what all are important. Number one is your presentation. Then make a quick DD. Don't make a wild differential diagnosis. You say the congenital hernia-like situation, inguinoscrotal swelling. How come you give a diagnosis of lymph node enlargement? You cannot. So confine your DD based on your findings. So your DD should be telling with these findings. Okay, even a lipoma of the cord is not common in congenital situation. So that also can be avoided. A varicocele is also not common. So don't give all adult DD in pediatric patient.
I'd just like to ask one more question on this regard. Suppose this child has got undescended testes on that side with the hernia and it has become strangulated. What operation will you perform? Strangulated hernia with an undescended inguinal testis. What operation will you perform? You have to go in immediately because there is obstruction, strangulation, you have to save bowel. So which operation will you perform? Will you do
Priority
only
is what?
herniectomy, reduction of the
Strangulated
bowel?
hernia and
and
undescended
abdomen?
testes.
Immediate laparotomy.
Laparotomy? It's in the groin only. Why do you go for laparotomy?
The organ is
What do you
strangulated.
do normally for strangulated hernia?
Our actually, most of the surgical decision has the intention that any strangulation they will laparotomy, but I always say that that is not required. You can manage the whole strangulation through the groin approach only. Okay.
Laparotomy is required for very late cases when the
Yes.
patient is almost in shock and you obviously know that you have got an extensive bowel gangrene.
Yes.
Otherwise, explore groin first. After exploring groin, mop up all, suck up all the serosanguinous fluid from the obstructed bowel. Try to return the circulation by putting wet mop, 100% oxygen inhalation. If it is viable, reduce. Then if it is associated with undescended testis, strangulated hernia and undescended testis, you do the orthopexy at the same sitting, even if it increases your operating time. Because if you only reduce the hernia and ligate the sac at a different second sitting, it will be very difficult for you to pull the testis down to its normal position because of the surrounding adhesions. So especially in neonate undescended testis, it is very common to have strangulated hernia, but in those cases also orchidopexy is required to be done at the same time. Okay, that's all. Thank you very much.
Okay.
But you can proceed with your next case.
Okay. So. Your Hyperspecies spelling is wrong.
Oh,
That is
sir,
important.
also,
DI?
DIS.
Yes. Okay.
A 5-year-old male child hailing from Nadia, West Bengal, presenting with passage of urine from undersurface of the penis since birth, causing swelling of clothes, downward curvature of penis. History of present illness. Patient was having the problem of passing urine from undersurface of the penis since birth. Parents observed the child was passing urine preferably in sitting position. He had difficulty in directing the stream of urine, and stream spraying was there, and he used to see the bending of penis. No history of burning, micturition, and fever or pain. History of past illness. No significant history of medical or surgical treatment was available. And birth history. Antenatal history, maternal age was 26 years, no history of OCP use, oral contraceptive pill. Perinatal history, birth order was 1 term delivered by cesarean section, birth weight was 2.8 kg, exclusively breastfed. Postnatal history, nothing was significant. And immunization history, all immunization received as per schedule. Personal history, diet was vegetarian diet. Sleep pattern and appetite was normal, bowel habit normal, and bladder habit, passes urine in sitting position. Family history, both parents are healthy. He is a single child. No other member of the family suffers from this condition. Summary, a 5-year-old male child from Nadia, West Bengal, presented with a urethral meatal opening under surface of penis with a ventral curvature since birth, along with micturition difficulties such as spraying and swelling of clothes. Should I proceed?
Yes.
Examination, general examination. The child was examined in well-lit room after taking parental consent and exposing umbilicus to the mid-thigh. Active, alert, and playful. No cyanosis, clubbing, and pallor icterus was noticed. Anthropometric measurement, height, 106 centimeter, weight was 32 kgs, mid upper arm circumference 13 centimeter. No other congenital deformities were noticed. Vitals, pulse rate 96 BPM, and BP was 90 by 60 mm mercury. SpO2 is 99% in room air. Respiratory rate and temperature were normal. Examination of the genitalia, inspection. The urethral meatus opening was seen at the middle of the penile shaft, not at the tip of the penis. The shape and size of the penis appeared normal. It has a ventral curvature when
appears small. Shape and the penis appears small.
And it has a ventral curvature. When asked to void, he did it in sitting posture. There was spraying of stream and the direction could not be controlled. Prepuce, a hood of skin seen at the tip of the penis, absent on the ventral aspect. Scrotum, no obvious deformity was noted in scrotum. Palpation, penis is small in size. The groove in the ventral aspect was deficient on the distal part, has a ventral curvature. Found tissue palpable at the ventral aspect from the meatal opening to the penoscrotal junction. Preputial skin deficient on the ventral aspect. Meatal opening present at the middle of the penile shaft. On the retraction of the foreskin of the urethral opening at the end of the penis, it was absent. And testes, bilateral testes were palpable. Bilateral hernial orifices were normal. And systemic examination were found to be normal. Summary: a 5-year-old male child from Nodi, West Bengal, presented with urethral meatal opening at the surface of the penis with a ventral curvature since birth, along with micturition difficulties such as spraying and swelling of clothes. And on examination, urethral meatus was found at the middle of the ventral aspect of the penile shaft, which is small in size. The shaft is small in size and has a ventral curvature. Prepuce has a dorsal hood. My provisional diagnosis is a case of Hypospadias in a 5-year-old child with no other abnormality.
You describe the penis once again.
Penis is small in size. The groove in the
ventral. What do you
ventral.
mean by small in size? How do you describe? It is called stretched penile length.
Stretched
Especially
penile.
if the child is obese, the prepubic fat is so prominent that the penis stays tucked in. So you have to press the prepubic fat with one hand and stretch the penis. There again, some examiner might pull your leg, that how far will you stretch. This is gentle stretching. So there is, especially in cases of where hypospadias is associated with sexual ambiguity, in those cases micropenis and other penile abnormalities will be there. And phallic length assessment is very essential for planning your surgery. So penis is small in size, it's just not in length. You will have to palpate whether the corpora, some of the patients will have one corpus absent. The corpora are of also adequate size, and the shape of the glans, it is a very narrow conical shape or it is somewhat wide. That has also got an important connotation on your surgery. And you'll have to describe the meatus. The meatus, whatever its position, you said mid-penile. So in your provisional diagnosis, it's case of hypospadias. My case is a case of mid-penile hypospadias with adequate meatus. You definitely have to observe the stream of the urine. And only in cases of perineal hypospadias or scrotal hypospadias, patient passes urine in sitting posture. Otherwise, even in proximal penile hypospadias, patient can pass urine in standing posture. There may be dribbling, there will be soiling of clothes and shoes, but passes urine in standing posture. So many a times parents try to mislead you that my son's urine stream is very narrow, like passage of water through an injection syringe, but don't rely on that. You'll have to see the stream yourself, and you can assess the meatus by use of number 5, number 6, number 7 sterile infant feeding tube. So is there any, the diagnosis is obvious, there is no differential diagnosis, but you'll have to describe the urethral plate also. Is it wide urethral plate? And how far is the urethral plate extending? Does it extend up to the glands beyond the coronal sulcus. And the glands, if you stretch the urethral plate, then you can see that the glands is flattened, and then if you release it, it opposes on the urethral groove. So that is called the deep urethral groove. For Hypospadias, you will have to describe this. And this urethral plate, it is not, what do I say? It's not ectodermal in origin. It comes from the bladder. It is endothelial in origin. That this urethral plate is very important. You will have to describe the urethral plate. Okay, how will you manage the case? You have to do any investigation? Would you like to do any investigation?
Yes, ma'am. Ultrasonography of QB region, this case,
and post-void residual urine. You can be sure that there is no obstruction in the outflow. Another thing is, for a reconstructed urethra, after you have done urethroplasty, it is very difficult to perform cystoscopy and other things. So, especially in proximal penile urethra, association of other associated renal anomalies, vesiculated reflux, bladder outflow obstruction, these are very important, but not so for granular hypospadias and distal penile hypospadias. So most of the examiners do not like to do any investigation for distal hypospadias, but for proximal hypospadias, at least you will have to perform an USG KUV and PVRU, and if there is any abnormality, you will have to go for micturating cystourethrogram. Okay. And any other investigation will you like to do?
We check whether urinary tract infection is there or not. For that, urinary REME routine examination and culture sensitivity of the urine.
No, at least in exam, you might be doing that in your OPD, but at least in exam, do not say so. Do a routine urine. If there is pulses and if there is symptomatic, then you send a sample for culture sensitivity. Otherwise, don't overburden your laboratory by sending routine urine and culture sensitivity for all cases. There is no pulsal in urine. While you go for culture sensitivity, a routine urine is enough. And another thing is you'll have to do a coagulation parameters, because most of these cases are done in as daycare cases, and especially in my current practice, we have seen the Hypospadias incidence has become very high, especially in population where consanguineous marriage is in vogue, and in them the abnormalities of coagulation parameters are also very high. So you'll have to take a history of that, and I think it is safe to assess coagulation parameters before the surgery. Okay. So for your case, there is CODI and there is mid-penile hypospadias. What are the aims of performing hypospadias surgery?
First, correction of the body, that is orthoplasty, and then I will. Hello, madam.
Correction body orthoplasty. Number 2.
Number 2 is a urethroplasty,
And
then
third is granuloplasty.
Granuloplasty.
Granuloplasty. And the appearance of the reconstructed urethra and penis will that of be a circumcised normal penis. You have an ugly, bulky dorsal preputial hood, so you will have to do something about that. You are utilizing most of the dorsal preputial hood for your reconstruction, but ultimately the end result will be, it should appear. Where will you position the meatus? What does the normal urethral meatus, where is it positioned and what does it look like?
It is present at the tip of the gland and
just ventral to the tip of the glands, just not at the tip of here. It's just on the ventral aspect, and it should be slit-like. Don't make it circular. And normally it is coapted. It should be so deep and such configured that the lips are coapted, open thakben. That's it. So what operation will you perform for this patient? CODI correction. So what are the different types of CODI? What is CODI and what are different types of CODI?
Chordae is the ventral curvature of the penis, penile shaft due to the
Chordae can be ventral chordae, chordae can be lateral, chordae can be dorsal. Which case you get dorsal chordae? Opposite of hypospadias. In epispadias, you get
Epispadias.
dorsal
Yes.
chordae. But in hypospadias, you can get both lateral chordae as well as ventral chordae. So chordae is due to
Dorsal.
what are the structures responsible for chordae?
The
You are
shortening
not
of
visible to me. Please.
shortening of tunica albuginea, shortening of the skin fold over that region.
So there is skin chordae, there is fibrous structures from the meatus to the glands, which will produce this ventral curvature, and there will be shortening of the corpora cavernosa also, especially that is responsible for lateral chordae. Sometimes there may be fibrous bands progressing from the urethral meatus to proximally also. There may be proximal chordae. So you will have to remove all fibrous structures from tunica albuginea. So how far will you proceed while performing excision of chordae? What are the layers of wax fascia?
That means you have to lyse this fibrous band. How do you go inside? What are the different fascial layers? You know the disposition? There is a fascial layer around the corpora cavernosa, each, and around the corpus spongiosum. And there is another fascial layer which invests all three.
You'll have to read the cross-sectional anatomy. Okay, the fascial layer, as sir is saying, which engulfs both corpora cavernosa separately. It has got two layers, outer longitudinal and inner circular. So you might have to excise the outer longitudinal layer, which is usually fibrous. The fibrous tissue you pick up with fine forceps and excise as far as possible, but you do not disturb the inner circular layer. Then there will be damage to the corpora cavernosa and there will be excessive bleeding. So how do you know that your chordae has been completely corrected? By what method?
By artificial erection.
Good. How do you perform it?
By giving injectable PGE1 or injecting normal saline. Either
So
injecting
you
normal
first
saline or
put a tourniquet at the base of the penis. And how much saline? How do you inject? Where do you inject?
sorry ma'am, that I don't know.
Hypospadias case present করতে হলে এগুলো তো করতে হবে বাবু, তাই না? You take a 2 cc syringe but change the needle to an IM needle. Do not inject more than 2 cc. It should be clear normal saline. Put a tourniquet at the base of the penis and you inject in the glans, because glans has got vascular communication with all the three corpora. So you inject it in the glans and then you see from the lateral aspect whether it has been corrected or not. Suppose you have excised all fibrous tissue, still it is not corrected. What can you do? Dorsal plication or Nesbitt's plication. Okay.
Yes, ma'am.
What urethroplasty will you perform for this patient?
The opening is in the mid shaft of the penis. You have to take it up to the near the tip. So what should be the procedure?
That is TPIF.
Tubularized?
Tubularized partial island flap. Preputial island flap.
Okay. By whose name is this operation? Duckett's urethroplasty. Or if you do not separate the pedicle of the preputial island from the dorsal penile skin, then it is Ashoka 2. And if you separate the pedicle, then it's Duckett's urethroplasty. You have got a very good urethral plate, and urethral plate is not responsible for your body. So you will have to make every attempt to preserve the urethral plate. And if the urethral plate can be preserved, which operation can be performed?
Utilize the urethral plate to create the new urethra.
What is tips? Tubularization of incised urethral plate and then cover it by urethral plate. টা তো শুধু বানাতে হলো না, ওকে তো অনেকগুলো জামা পরাতে হবে।
Is it Snodgrass?
Snodgrass.
Yeah.
Tips is Snodgrass. Snodgrass is urethroplasty.
Okay.
So Snodgrass is only after incising longitudinally the urethral plate, you tubularize it over an infant feeding tube. But you have to cover that tube with something. You can cover it with de-epithelialization of the inner preputial skin, that is Bellman's flap, or you can cover it by a pedicle flap from the testis's upore ki thake, tunica vaginalis.
Tunica vaginalis.
Take a tunica vaginalis flap to cover. It is very essential that you have some sort of coverage to prevent post-operative breakdown. Okay. Which part? And about the danuloplasty, you haven't said how do you perform danuloplasty? You create glans wings by excising small triangular flaps on both sides of your incision, and you bring that glans over the reconstructed tube. Otherwise, glans will remain open. Glans shape will not be, it is basically a cosmetic surgery. And if you do not do a granuloplasty, the meatus will recede to the coronal sulcus. There are many.
Create the glans flap
and then
over the
tube.
New urethra formation.
Sir, কিছু প্রশ্ন করুন, আমার মনে হচ্ছে।
No, you have covered this. So now the question left is complications of hypospadias repair. You must know. You must be knowing the Ashopa's technique. Madam has talked about that. That is a tubularized urethroplasty. Okay, and now Ashopa has been replaced by other techniques. Okay, is the Ashopa still being practiced, or it is replaced by other techniques, madam?
No, Ashopa is still very much practiced. It is not replaced as yet, especially for proximal hypospadias. Ashopa's technique is very much in use. Actually, Snodgrass procedure is not suited for all cases. If it is a very distal, very long length of urethra, you have to reconstruct. Ashopa may not be suitable. The urethral plate may be Snodgrass may not be suitable. The urethral plate, if it is very narrow, it cannot be used. In all those cases, case selection is very important. Which operation to be done in which case, and it is absolutely individualized. There is no hard and fast rule. So what can be done for a particular patient? That is to be decided by the presence of body, the position of the meatus, and the condition of the urethral plate. With minimal body, good urethral plate, Snodgrass's urethroplasty is a very good procedure. But for proximal penile hypospadias with body, we have to resort to other procedures. At what age will you perform? That is very important. Half the time I see a neonate with an hypospadias has been sent by 102 ambulance to NRS. Some emergency operation is required. Is it so?
What is the ideal age?
Operate
6
on
months to 12 months. 6 months to 12 months.
It depends on the surgeon. Some surgeons, especially at Agra, those who are practicing urethroplasty only, they prefer to do it before preschool stage, because the child does not become conscious about the his genital abnormality at that age, and it is easy to keep the child in double diaper technique. That is, you put in the catheter, cut the catheter, and make one hole in a diaper, take that cut end of the catheter out, and you put in another diaper. So you change the external diaper only and change the inner diaper only when the patient passes stool. In that case, the child does not have to move around with a bag, and there is no danger of pulling the catheter out. Especially a preschool child who's very restless and does not stay still, it's very difficult to maintain at least 7 days, 7 to 10 days with catheter they have to maintain. But the phallic size is very important. It's not the child's age. It's the size of the penis. The glands should be broad and the penile length adequate. In cases of, especially in case of micropenis, is there any role of hormonal treatment?
Yes, ma'am. To increase the size of the penis.
So what can you do? Which hormones can you use?
Androgenic hormones.
How? What are the routes? What are the routes of administration of androgen?
Because systemic that causes early fusion of the urethra, epiphyseal plate and height shortening. So you give beta HCG. Okay, 2 injections 2 to 3 weeks prior to operation at a weekly interval, but not too much of beta HCG. Even that causes degeneration of the seminiferous tubules. So sometimes we use topical anabolic steroid in the form of Sarno's cream, testosterone cream, or testosterone injection, aquaviron injection mixed with Nivea cream can be applied. But that has to be stopped if there is hirsutism or the darkening of the external genitalia skin. Sometimes it gives good results. There is increase in phallic size so that one can operate. Suppose you said it's a mid-penile prestige, so it is a proximal penile hypospadias. Then what operation will you perform? Can you do single stage, multi-stage? That's what I wanted to ask.
Multi-stage, 2-stage operation.
Yes.
What is the first stage and second stage?
First stage will be orthoplasty and the preputial skin to be placed ventrally, and then in the next step, new urethra formation and granuloplasty, myotoplasty along with granuloplasty.
So, have you heard of snot graft technique? What is snot graft?
Sorry.
While performing orthoplasty, if there is not adequate preputial skin and the urethral plate is very bad, after correction of the body on the ventral aspect of the penis, where you will perform your second stage operation later, you place a quilted graft of inner buccal mucosa for later use. Tubular, that is the graft, it's not graft technique. You excise the fibrous, narrow, short urethral plate, and in that bed you put in a buccal flap, even an inner preputial flap, quilt it, apply some for 6 months, wait for 6 months, apply from topical steroids so that it does not get fibrous. Then you tubularize it and operate. Second stage urethroplasty. So what is the post-operative care that is required? Most of these patients require post-operative urethral dilatation, which is the parents are taught. First, they do it daily for 6 months, then once a week for 2 to 3 months, then every birthday. Usually after 1 or 2 years, post-operative dilatation is not required. So let us summarize once again the complications of hypospadias surgery.
There may be meatal stenosis, there may be bleeding or hematoma, there may be ureterocutaneous fistula, urethral stricture.
Complete disruption.
Yes, ma'am.
Incomplete chordy correction, and there will be some residual chordy giving lateral curvature, some sort, and sometimes during all these flaps operation, there is torsion of the penis because we are degloving the penis and then rotating the skin flaps to cover. So there may be torsion. Up to 15 degree of torsion is acceptable, but more than that, some surgery has to be performed. But for that, it is better to wait till onset of adolescence period, till the phallic group, because most of these defects are corrected once the patient reaches adolescent period with penile growth, and those which are really bad will become more prominent. Then your assessment is complete. Yeah, after at the puberty, if you do the secondary surgery of penile torsion or any other deformities of that sort, then you get to know what will the actual erect penis will look like. But urethrocuteneous fistula should be operated within 6 months of initial surgery. Anything else, Professor Shah? Will you?
No, we have covered this basic important part of the MS examination. The little about the development also should read. How does the urethra develops? Okay, because that explains the genesis of Hypospadias. So the mic is there? No. Any question from any of the participants? Any question?
Sir, I just want to ask the question which ma'am asked previously, that in a strangulated hernia with undescended testis, we have to go for herniotomy as well as orchidopexy.
Yeah.
So, sir, is there any chance that the testis might also be affected? And second, sir, since it was undescended, do we need to do the orchidopexy on the other side as well?
No, if other side is normally descended, you don't need to intervene the other side. Second is, when you have a strangulated hernia, the hernial content is getting strangulated. The testis is outside the hernial sac. So if the testis is not rotated, there is no question that testis will be affected by this strangulated hernia. Strangulated hernia is because of narrowing of the neck, twisting of the hernial contents. So that probably does not affect the testis as such, so that the testis become gangrenous. Okay, so you tackle that strangulated hernia part, do the herniotomy, and then mobilize the testis to bring it into the scrotum. The other side need not be explored. No. Madam?
Okay, sir. And
Yes, I agree with you fully.
Yes,
and,
Ishita.
sir, how do we, sir? Sir, since I have not seen any such case, just asking, that's why. So, how do we differentiate that it is a strangulated? Means all signs of strangulation will be there, but the swelling is like the torsion of undescended. It is not a torsion of undescended testis, and it's a strangulated hernia. Means how do we differentiate that?
You answer this question yourself. What gets strangulated in strangulated hernia? The abdominal contents, the intestines. So what will be the abdomen like? Abdomen will be tense. Patient will have distended abdomen, vomiting. Patient will be much sick in strangulated hernia than in torsion. And in torsion testis, that there is a typical presentation, that is the redness of the scrotal swelling, and the abdomen is soft. And if you elevate this scrotum, there is more pain. I cannot feel the testis separate.
No, ma'am. I was asking that if it is strangular, means torsion of that undescended testis.
Undescended testis.
Means in the groin only, and means the difference between the strangulated hernia associated with torsion of undescended testis.
There will be no abdominal features. In case of strangulated associated hernia which gets strangulated, the abdomen will be distended, patient will be in shock, in distress. But the torsion of the undescended testis, there will be redness and swelling of the groin area only. The abdomen will be soft. There will be no bilious vomiting, no abdominal distension.
Okay.
And mother might be saying that the classic history, that the swelling is coming up on these activities and then reduce and lying down. So if you have a classic history of hernia in the history, then you should always think that patient has got associated hernia. All undescended testis may not have associated hernia.
Okay, sir. Thank you, sir. Thank you, ma'am.
Thank you.
Welcome.
Thank you, madam. Thank you very much.
Okay. Thank you, sir.
Thank you.
I'm leaving the meeting.
Okay.
Thank you.
Yes. Yeah.